That's one thing I noticed with my other class, is they kind of throw some, this book kind of throws out definition, well, not definitions, they throw out concepts without defining the concepts, kind of with the assumption that you already know that, and perhaps some of these concepts I doubt were seen earlier in the book. So, so we're going to go over some of that. This chapter, we'll probably be on this chapter for, well, at least, more than today. So I guess a couple of weeks before we move into chapter 8, which is uncommon pathology. I see, look at that. So here's the thing. Some of the things that they mention here in chapter 7, and that's what I'm kind of saying, they just kind of mention it without going into it. It's like, what the heck? Well, now I'm looking at chapter 8, and I wish I had done that a little bit earlier. I see some of the things that I had kind of planned on talking about. So, yeah, that's kind of 7 and 8. Really, I don't know why they separated them into 2 different chapters. So 8 is going to be really short because probably just by happenstance or just by the fact that it's mentioned in 7, I'm going to go over some things, and it's probably going to come up again in 8. So when we do go through that, that will be short. So maybe by next week we'll have not only 7 done, but 8 done as well, which will be good. That'll put us, I think, a little bit ahead of schedule, which is always a good thing. So chapter 7, I'm not really going through it in perfect order. I'm certainly going to skip the first couple of pages, avoiding repetitive stress injury. Well, I already talked to you about that in lab. Keep that elbow, keep that shoulder down, keep those wrists from being bent, hold the transducer lightly, and all that stuff. Patient positioning, patient preparation, and equipment, we're kind of more or less learning in lab. And scanning technique, we're also learning in lab. So what I want to show you today is, obviously you can see on the image here, I've got a bunch of pictures. And I think it helps, I forget, obviously I think this author forgets where you are in your education. Sometimes I forget too that you just need a lot of imaging. You need to see a lot of ultrasounds in order to kind of understand. Because we could talk about the concept of stenosis, but without actually seeing one, it's harder to get. And once you see it out in the field, then it's like, now I get it. Now I get it. So, all right. Someone with a doing some work next door or something. Okay. Pen. All right, so let's talk about this. I'm going to go through these images in the order that I have them. Like I said, it's not perfectly aligned with the book, and the book kind of just didn't really make it that easy to follow in this particular chapter. That's okay. All right, so we've got 2 images in a row here that are the tuning fork. You will not find this on most people. So when you see this in transverse, of course, what you're going to see, you go transverse, like right there on someone, you're going to see, let's see, right? And the same thing with the picture below. Most of the time, though, you're not going to see that. You're going to see some kind of variation like that. On the other side of the neck, it'll be the opposite. So just consider yourself lucky when you get one of these images because they're just fun to have. But we have here, this first image is a very healthy looking system as far as we could see. The distal carotid is crystal clear. Notice, by the way, that muscle. You see, here's the problem with radiology ultrasound of the carotid. And when I say radiology, that means you're a general ultrasound technologist. You're working all over. You have your own lab. Sometimes you go on portables. You're up in the patient rooms. You're in the ER. There's really only one way that we do ultrasound, and that is standing on the patient's right side and scanning just the way we've been doing in class. A superior way to scan a carotid is actually sitting at the head of the bed. So the patient's head is right in front of you, and scanning in such a way that your arm is resting on the pillow next to them, especially on the right side. It's very easy to make that scan. I'm sorry, I have. Another student asking me a question that I had to answer, sorry. So yeah, if you're doing carotids all the time, all day, every day, learn to scan from the head. And we'll do a little bit of that in class. And there's the right side of the neck is very easy. You actually have the machine over on the other side. Left side is a little bit differently, but the way you're sitting there, it's very easy to come around. It's, we scan here. I suggest that you come around to here in order to get through that muscle. And when you're scanning from the top of the head, it's not only easy to go from here, you can come all the way back to here if you really need to and really get that more muscle in between. But why do I mention this? Look how crystal clear. By having that muscle there, and we know it's muscle, by the way, you can see these striations. It's actually striated skeletal muscle. It really makes for a clear image. Unfortunately, difficult for us. And so I think I've shown all of you in class the difference between going through the muscle and then going through all of those layers. Okay, another student, same exact question. I'm not going to answer it this time. Why are they even asking that question? I don't know. Okay, so moving forward, and just from imaging this, we pretty much can guess that this is the internal and the external. I could be wrong, but I really doubt it. When you look at the ECA, is smaller, starts smaller. The ICA is oftentimes part of the bulb itself, and so that swirling motion of blood will continue into the real proximal ICA, which tells you might, when we take an image and we take a spectral of the ICA, sometimes really proximal isn't appropriate because it's still swirling around, and it's going to show you an unnecessarily ugly waveform. Let's see. Now this one, this is also crystal clear here, but look at this. We have muscle, vein. The vein is really an awesome, if you can use it, and usually you can't, but if you can use it, it's a great window. These are, let's see, muscle is a good window. The vein, if you can use it, Great. Window. And of course, when I say window, it's meaning you see things through windows. But look at this, look at that, look at that. That's just beautiful. That ICA is a little bit bigger. Clearly, that is what we're looking at. Anyhow, I guess there's not much else I could say on these other than they're beautiful imaging. I will say, we're going to mention this in a second anyway, but we can really see the different layers of the vessel. That outermost echogenic layer is the tunica adventitia, the outer, that's the outer jacket. More of the hypoechoic region is the tunica media, so that's more really where the muscles are. And then this innermost is the tunica intima, the most intimate, the most inside layer. And we do pay attention to that. Okay, well, once again though, another crystal clear carotid artery. And then we get the other stuff, and I kind of scribbled that in there to remind myself to talk about the heterogeneous nature of this plaque. And so we do have plaque here. We can kind of get a guesstimate, only a guesstimate on how bad the plaque is. Now, I'll tell you why that is in a second. Because you can, let me just say, plaque sometimes looks horrible, but then turns out to be hemodynamically insignificant, meaning the hemodynamics don't actually change all that much. Now, that's not to say that plaque in and of itself is insignificant, because it might be hemodynamically insignificant. In other words, it's not creating a big pressure drop because of a big stenosis, but of course, it's still plaque. And if any of it breaks off, that is significant. So when I say hemodynamically insignificant, it doesn't mean it's not trouble. So this plaque here is, well, we're going to call it heterogeneous. And the reason we're going to call it that is because, let's see, I need the right color here. We have echogenic portion.
I'm in class, baby, what?
Let's see if this shows up a little better. All right. We have echogenic portions. We have portions of the plaque that are very hard to see. We might even have hypoechoic portion here, which is even a little more concerning. So this plaque is really messy. And a lot of people believe, not everyone, but a lot of people, including me, believe that you can kind of guesstimate the danger of embolism from the appearance of the plaque. We'll talk more about that. Let's see, so this plaque is heterogeneous. So let me finish. You can look at it and say, oh my God, that's horrible looking. And then you do the Doppler and it's like, okay, not so bad. So it is hard to say for sure what kind of plaque you're dealing with. Oh, and this is also, this person's probably in a lot of trouble because look at this. CCA proximal. The only time I've ever seen proximal is when distal is really bad. Because normally plaque starts to develop right here, right here, right there, right there. In other words, distal CCA, bulb, proximal ECA, and ICA is where we see the majority of the plaque. When we see it down in the carotid proximally, person probably has pretty bad plaque throughout, and so they're probably in bigger trouble. Now, here we have a totally different plaque, and we're going to call this plaque more or less, most of it is homogeneous. And we'll call it hypoechoic. It's not hypoechoic as compared to the lumen. Lumen's anechoic. So, but it is hypoechoic plaque. It's certainly not, yikes. It's certainly not echogenic plaque. Sorry to beat on the glass like that. I'll try and stop doing that. So this is more or less homogeneous. At least it's homogeneous and hypoechoic, kind of all along here. Now, some people consider this more dangerous than the more scary one. So that not only can this be hard to see, if it were a little more hypoechoic, this would be almost isoechoic to the lumen. And you can imagine, this is beautiful imaging. If this were ugly imaging, if we had a lot of all this reverb artifact in here, a lot of artifact, you might see where that plaque would be completely hidden to us because of all this artifact. The problem I have with people in this town, the problem I have with you people, no, I'm just kidding. The problem I have with actually the radiologists in this town is that what they want us to do is just darken the screen until all of that stuff goes away. But of course, we know what happens. That's going to go away as well. So we do have to be careful. Now, this person has...
Kurt?
Yeah.
Quick question. Because in all my years of working diagnostic radiology, and watching it go from film to digital, the radiologist, because we had to sit down with them several times throughout my career, they were able to start changing the window, the shades of gray as they did that. Are they able to do that here in ultrasound? Because if they are, I agree with you. Why are they wanting us to get rid of it when they can change the grayscale themselves and see everything there?
Yeah, and so it's called post-processing, and they do. They're certainly able to change the gain. We could change the gain after we freeze. They could anything we could do after we freeze it, they can do. And so changing the gain is one. Oh my God, I can't remember if reject should be one. Yes, they can. Of course, they don't want to spend the time. Their entire income is designed around speed. So by the time it takes us to do one of these exams, they've read 15 other exams, right? Probably more. But you're right, they are able to change it. I'll give you guys a little heads up. Some of the newest machines that are just hitting the market, these are upwards of $1 million machines. They are supercomputers, and they're gathering so much information that the post-processing, that we have very limited post-processing in our machines. The post-processing is going to be unbelievable in the near future, which I told someone about that. Oh, my doctor, and he said, Kurt, that scares me because now lawyers are going to have access to all of that post-processing too, and they're going to go through and be able to extract all sorts of information that might have been missed by the sonographer and the radiologist. And so he says the more information that is out there, the more it's better for the patient, but it's also worse. Maybe too much information.
Do you think the technology is going to get to the point where basically we can have like a wireless transducer connected to, say, like an iPad or a Surface Pro?
Oh yeah. Yeah, sorry to interrupt you. Yeah.
No.
It's already begun. The good news, guys, when I was a student, I was very concerned because I kind of see where technology is going. Well, any of us can. I don't have any special insight, but my concerns were, well, why are they going to need us, right? And people have had that concern for decades, and so far, anyway, the more technology that is attached to these machines, the more specialized they become. And so, yeah, sometimes just finding something easy, all right, you can train a nurse to do that. But then again, we're not here for the easy stuff. We're here for the hard stuff. And so now we're going to be getting to the point where we're going to see more and more and more stuff. And so as machines become more incredible, you think, oh, well, then anyone can do this. It's actually, so far, it's been the opposite. It's been the technologist needs to continue to increase their knowledge base, because now we're seeing more and more. And this is a good example, actually, because this one has what we call interplaque hemorrhage, which I will kind of circle here. An interplaque hemorrhage, well, that's kind of that means bleeding, right? Where is the blood coming from? Remember, I mentioned that arteries, veins they have blood vessels inside the walls of the blood vessels. They are vasovasorum. And
so is that kind of like an ulcer?
Yes.
On the plaque?
Yep. So plaque is actually living material. We don't think of it that way. We think of it as something that's stuck. No, it's actually living material. There's fat cells, there's lipids, fat cells, foam cells, which are filled with fatty lipids, blood vessels, muscles, connective tissue, muscles as in like the very muscle that's normally around the outside in the tunica media has grown into there as well. And so when these things hemorrhage, they could actually hemorrhage. The problem with the hemorrhage is now this whole area has become weakened and can tear off. And then it's an ulcer. I was just reading in your book, though, that they said avoid the use of the term ulcer because it'd be very difficult for us to, it'd be very difficult for us to truly diagnose an ulcer, whatever. An ulcer, by the way, guys, if you've forgotten, an ulcer would be more of a dip like that, where something's already broken away, so it's ulcerated, kind of wound. So let's see. With interplaque hemorrhage, you could also have the unusual formation of thrombus. Thrombus, in other words, a blood clot, very common in veins. Veins are very slow-moving vessels. In any kind of injury to the vein, you can get thrombus. In arteries, we don't get thrombus generally, we get plaque. But sometimes we can get thrombus. And so what can happen in the case of really bad plaque, plus a hemorrhage, which ulcerates, which is now kind of like, there's actually thrombus was growing inside of that hemorrhage. This lake here was being filled with thrombus. Now you have kind of a combination of plaque and thrombus, and things can go from bad to deadly in a matter of seconds. Yeah. So those are two kinds of plaques we can see. And this one's beautiful, unless you're the patient, then it's not beautiful. Here, now we're really seeing, let's see, well, they're saying, right, ICA, so I'm assuming, let's see, we have bulb coming down here, and they put some calipers down here. Not 100% sure where the walls, the original walls are. And it looks like, okay. So let's see, one. Okay, so it looks like here we have the number 1, and we have a number 1 up there as well. Just erase those, it's getting ugly. That's probably original lumen. And then number 2 is here to here. Get rid of that. That's remaining lumen. So let's see, 1, 2. Okay, so it looks like they're doing calculations after the fact here, I think. But by knowing these two measurements, original lumen and remaining lumen, you can take you can work out the, the percent reduction. It's basically a ratio, right? But, and that's fine, and by all means that is fine. The gold standard, though, in finding out percent reduction is actually in Doppler. So how fast that blood is traveling is actually the gold standard. The reason being is because this is a one-dimensional image. There could be more lumen that we're not seeing, and so we could under or sometimes overestimate the amount of stenosis by measurements like this. But by all means, take these measurements. It's just not quite the gold standard. And you can see number 3 here is just a measurement of the thickness of the plaque. It looks like most, and let's just, well, the plaque extends into the distal CCA. So all of that is plaque. I would say there's plaque on this side as well. And of course, it wraps around. Remember, one-dimensional image of a three-dimensional object. When you see plaque posterior and plaque anterior, it's not two separate plaques. It's actually plaque that's surrounding the entire vessel. And so this vessel is surrounded with this plaque. This is one really piece of plaque. It's just thicker on the posterior side than the anterior side. But we could see no aliasing over here. Velocities really haven't increased, but aliasing here. And so this is telling us also where to put that spectral. When we do put that spectral in, we're going to walk it through. Of course, it doesn't show up. We're going to walk it through. We're going to try, it's still not showing up great, but anyway, we're going to try it there, and we're going to, we can move this. We could track, without moving our scanning hand, we can trackball this and slide it through. And if you lose, you kind of lose it. You hit set, figure out where you're at, and start over again. And you're going to go through, and you're going to find the highest velocity. My guess, just looking at this, is the velocities are very high. I guess I really can't garner a guess because it's hard to say for sure. But I could at least say the velocities are going to be quite high in there. Another one. You could see laminar flow here, at least somewhat laminar, although a little bit of flow separation, that little piece of blue, that means this is probably the bulb, but not a very obvious bulb. But then look at this, look at the amount of, we've got this narrowing in here, narrowing in here. What was that?
How can you tell that's the,
Well, how, as you cut out, but I think you're just asking how could I tell it's the bulb? The flow separation. So that little bit of blue, that little bit of blue right there, that says flow, and I can never spell separate. I always get my separation. I never know. But that's flow separation. In other words, flow goes into the bulb, and there's always a little bit, sometimes a lot. If it's a big bulb, it goes, like a big washing machine. If it's a smaller bulb, there's just a little flow separation on the edge. But we could see that that's not aliasing. That is a reversal of flow. Over here, this is all aliasing. And this whole area there is aliasing. Right yellow back here. So plaque, of course, this is all one big piece of plaque. It's just, and we're seeing a lot of aliasing, a lot of disturbed flow. Well, continued aliasing. Looks like they've measured, looks like they're measuring the length of the plaque, although I'm not really sure where they're saying it ends, but that's definitely a significant amount of plaque, a significant drop. And remember, it's the pressure drop. That's what's even more than the lack of blood, although obviously a lack of blood is going to be a problem. The pressure drop is the big issue there. And there's definitely a pressure drop with a stenosis like that. By the way, this is a pretty, well, it's a long stenosis in that it's probably 1 centimeter in length, but if it was several centimeters in length, then we go from Bernoulli to Poiseuille. Poiseuille says, remember, volume flow. See, with Bernoulli, we keep the same volume. Well, it's always the same volume, but we keep a high volume. We just jam it through faster. We put the thumb over the end of the hose there, and we jam it through faster, so that high volume can maintain itself. It's just now we've had a pressure drop. If you get a really long stenosis, Bernoulli no longer applies because Poiseuille takes over, and it's still, a 50 milliliters per minute in, 50 out. That doesn't change, but the overall volume has to go down. That other blood has to go somewhere else. It goes through the ECA or something. It goes through the ECA because it's not able to make it through the ICA. And that there's kind of a whole little section on talking about that we'll get into. Oh, this is awesome. Let me just, I use some continuous green. Here is, I think, the distal CCA. And probably the ICA. This could be, well, yeah, there it is, ICA. And look at this, deep, dark, shadow. Why? Because we have all this really echogenic plaque. And we were just learning the other day, or just yesterday, I think, that there's a couple of things going on. There's very high attenuation causing the shadow. That attenuation, remember, that's reflection, scattering, absorption. Well, here we have reflection, so it's very echogenic. That means a lot of reflection at the surface of this plaque, and so much shadowing that probably absorbed the sound wave as well. The shadow, all a shadow is a lack of information. Obviously, there's stuff back there, but we just can't see it. Now, here's the thing about this. It is scary. What's it mean? Like scary looking as heck, right? This looks, you see this, and you're like, oh my God, this person's in a lot of trouble. Well, there's a couple things here. Echogenic plaque is calcified plaque. Calcified plaque, some people believe, not everyone, but some people believe that calcified plaque is less likely to embolize simply because it's harder. So that's one good thing. So if that is true, this is less likely to embolize. Whereas the soft plaque, you know what? I never really named it. I gotta do this. Sorry. I can name this soft plaque, but we're gonna call this soft. Just kind of just a colloquial name. It probably literally is soft. If you opened up the vessel and squeezed that plaque, it would be soft. And this is more of a hard or calcified plaque. And here's the other thing about it. It's scary looking because we can't see through it at all. But I have seen, in fact, I think I have a picture. I have seen laminar flow going into this and laminar flow coming out. If it's laminar in and laminar out, this is not significant. It looks scary, but it's not. Now, if it's laminar in and then crazy on the out, well, then it's significant. We might not be able to see the actual stenosis. We might not be able to measure the highest velocity because the highest velocity is somewhere in here. So we could only extrapolate. And like I said, if it's laminar out, there's not a significant stenosis. And if it's really messy, then there is a significant stenosis, but we cannot, unfortunately, tell the doctor exactly how bad it is. Yes, and I do have an image. Okay, we're going through this way too fast. That's okay. I don't know for interesting. I don't know for sure, but it appears like it's laminar in and laminar out. But in this plaque, it's not super echogenic, is it? But it does create a heck of a shadow. So we don't really know what's going on in here, but it's probably not terribly significant because this seems to be laminar flow on the way out. I find this interesting, and I have suspicions on that, but we'll.
What about that that anechoic area right there on top of the word shadow?
You mean on top of the word shadow? It's like all in here?
Yes.
Well, I think isn't that part of the shadow? Because the shadow is being caused by that. Even though it's really not that echogenic, I'm actually very shocked to see a shadow this pervasive off of a a structure that's no more echogenic than the surrounding tissue. So it's really kind of interesting. So it's not, if it were super echogenic, you would say the shadowing is mostly from the reflection of sound. The sound just came down, bounced off, and that was it. But this seems to have absorbed the sound to an incredible degree without really reflecting more, because if it reflected more, we would see it. We would see it as very, very bright. And it's simply not. So this is weird. W-E-I-I before E except after C. Weird. I don't know. It's weird that I can't spell. I don't know what the major issues is. Anywho, moving right along. I do a great Kermit the Frog, by the way. I'm not going to do it right now, though, because I think my daughter's in school. Okay. This is the gold. In fact, I'm going to use yellow for gold. The gold standard. And there's a few things I could talk about with this too. So this is put out by the consensus panel. It doesn't say. Darn it. SRU. I can't remember what SRU stands for, but basically, radiologists and vascular surgeons, radiologists and vascular surgeons, they have meetings every once in a while, and they come around from all around the world, and they work this stuff out, and they say, what are we going to agree on? We're going to put this paper out, and hopefully everyone else, all our colleagues around the world, will agree with us. And so they come to a consensus of what standards they're going to go by. And of course, there's a lot of paperwork. There's a lot of studies that go into this. They don't just come up and make it up. Let me just put a little 60 degrees as a reminder here. Okay. So when we look at this gold standard, Doppler is the gold standard. Not color Doppler, spectral Doppler is the gold standard. It's the most reproducible. It always produces the same amount of velocity increase depending on what size vessel you're talking about. Whereas our visual assessment of plaque, we might think we're seeing it beautifully, but there is a limitation to our abilities, and sometimes people are really hard to scan too, so that doesn't help. But Doppler is Doppler. As long as you set up your Doppler correctly, Doppler is Doppler. So normal, when we say is normal, a peak systolic velocity of less than 125. I actually don't like that. I find healthy individuals, especially young athletes, with greater than 125 because they're young athletes. Their heart is like, oh. So, but that's why we have multiple things we look at. Less than 125 peak systolic velocity, none. The ICA-CCA peak systolic ratio. Now, I really haven't gone over this yet. I didn't mention it in lab, although I don't know if everyone got the same talk because we are two different labs. ICA-CCA peak systolic ratio. That is generally, not always, but generally the distal CCA peak systolic velocity. And the ICA of the highest velocity available. So usually proximal, but it could be mid or distal even. But usually, so it's usually distal CCA. And we choose distal CCA because the proximal CCA all the way down here is closer to the heart, and it can be artificially increased in velocity. So we don't necessarily want that artificially increased. It's just simply by virtue of the fact that it's right there next to the heart. And by the time it comes halfway up the neck, it tends to slow down just a little bit. Or it tends to normalize what its velocity will be. So distal CCA, ICA, highest velocity. So on a normal patient, it doesn't matter where you put it, it's going to be the same velocity more or less. But if you find a stenosis, the highest stenosis, the highest velocity in that stenosis is divided by the distal CCA. So and that's as simple as it is. ICA divided by CCA. These are just the peak velocities, systolic velocities. And that ratio, we don't multiply by 100, so it's not a percentage, it's just a ratio, should be less than 2. We do the same thing with end diastolic velocity, less than, oh, I'm sorry. Our machine does and I misread this, our machine does a ICA-CCA peak systolic velocity ratio and a ICA-CCA end diastolic velocity ratio. And I think I mentioned just yesterday, that's unusual. We don't usually see that. And in fact, this chart does not have an end diastolic ratio. It just simply has an end diastolic velocity. And so that should be less than 40. In other words, if you have a high end diastolic velocity, it's probably not because of a low resistance, it's higher than 40 anyway. It's probably because there's a stenosis there. Okay, let's use another color for the next row. Less than 50%. Less than 50% stenosis is hemodynamically insignificant, meaning there's not a significant pressure drop that's going to cause a pressure drop up in your head. So it's significant for other reasons, embolisms, for instance, but it's not significant hemodynamically. So less than 50, we still have a peak systolic velocity of less than 125. It's insignificant. Plaque estimate, this is a visual. Visual, that's an S. Visual is less than 50%. ICA-CCA ratio is still less than 2 because once again, sonographic or hemodynamically insignificant. The velocity change, the velocity increase through whatever stenosis has been created here is still so small that it's not causing great differences and still here. So in other words, the only difference between these two, normal and less than 50, is visual. We see some plaque, but it's not causing any problems. 50 to 69%, now we have some mildly increased velocities in the ICA. There's no ECA in this graph or in this chart because we don't care, right? So the ICA has a mild increase. I'll get in the carotid at the end here. Plaque estimate is greater than, maybe equal to, but greater than 50. The ICA-CCA ratio has now been increased between 2 and 4. And end diastolic velocity has increased between 40 and 100 centimeters per second. We'll use red because now we're getting into more trouble. Greater than 70, but less than near occlusion. So there's so much uncertainty in this, is that they don't want to, at some point they're kind of like, yeah, we're not 100% sure how to measure this, but we're going to say it's more than 70% stenosis, but not quite at near occlusion. So greater than 230 centimeters per second for the ICA. Plaque estimates the same. ICA-CCA ratio is now even greater at more than 4, and end diastolic velocity ratio is even greater at more than 100. Then we have, what would be orange. Orange is, of course, even more dangerous, right? Near occlusion. At this point, we're running into there's a phase change here where the velocities can be high, and I've seen them at 600 centimeters per second. They could be low. Suddenly, Bernoulli doesn't count anymore, and Poiseuille's comes into play because stenosis is so unbelievably small that the friction involved, it just slows everything down. And typically what happens is the stenosis starts to get longer or undetectable flow. You think there might be flow, but plaque is visible. No kidding. Variable. Well, of course, if we're high, low, or undetectable, it's going to be variable here. It's going to be variable there. Total occlusion, undetectable. No detachable lumen. In other words, you just don't see, you don't see lumen, period. Not applicable for the ratios. Notice that the carotid itself is not a part of this. Like I said at the beginning of lecture today, the proximal, even mid carotid is pretty unusual, so we really don't even have study. We don't have a chart for it. We just have more of like, hey doctor, look at this plaque and look at the velocities. You make up your mind from that. Now, near occlusion versus total occlusion, I think we'll talk about that next time, but this is really important. Very important to know the difference between near and total. But the other thing I wanted to talk about, and I will talk about this time, is 60 degrees. This is a little bit off. It's not really off subject, but it's a little off subject, I guess. 60 degrees is not the best. In fact, it's the best of the worst, if you really think about it, because at 61 degrees, the computer is telling us that our margin of error is so great that we're going to flag this as not reliable. 60 degrees and below is reliable velocities. And remember, this is, when I say 60 degrees, this is what I'm talking about. It's actually 60 degrees there. So as okay. So the wings in 60 degrees, and of course we'll practice making sure that we're at 60 degrees. It's not the best. So many students confuse this. 60 degrees is not the best angle. It's at the point where things get so bad it's no longer acceptable. The best angle ever is 0 degrees, straight down on the artery. Very often unattainable on ultrasound because that's not how arteries travel in the body. But 0 degrees is by far the best. There's no error with 0 degrees. And at 60 degrees, I believe the error is 50%. But we tell the machine how far off we are, and it fixes that 50%. But it would be better if there was no fix in the first place and we just had a 0 degrees. So Don't think that 60 is best. 60 is simply the best of the worst. The reason why we use 60 is because all of the thousands of studies that went into making this, almost all of them use a standard of 60 degrees. They're all using that standard. We tend to stay at that standard. So, so if there is inherent mistakes, maybe there's inherent mistakes in this chart because everyone's using 60 degrees. Maybe if we all used 0 degrees, these numbers would be a little different. But since we have to use the chart, we're going to use the same amount of error that they're using. So we tend to stick to 60. That doesn't mean if you get a nice a 40-degree angle because the vessel is really diving or something like that, go ahead and use it. You're not held. Well, most people, some doctors will actually hold you to 60, but most doctors are like, yeah, fine, go ahead and use 40 degrees. I don't care. Just don't use 65. Don't go over 60. Anyway, I just wanted to say that. Let's see, 10:30. What do we want to say about this one? It's a left CCA. Why? The left CCA. Their angle correct. This angle correct. Oh, that's why I picked this one. Look what they have here. I'm gonna do their spectral line is coming in like that. Their angle correct is perfect. But I don't know what these guys were thinking when they did their color. Now our machines can't do this. Maybe they can. They can't do it. They might. I might be able to manipulate the machine to do this, but in general, our machines can't do this. They can't color Doppler in this direction and spectral in that direction. So this person, for whatever reason, had a really bad angle for their color. I'm actually shocked that they got that much blood flow in their vessel because that's a horrible Doppler angle. Look how everything is traveling. Everything's traveling downhill, right? And so the color box really should be aimed the other way. They should be back on their heel just a little bit to help that Doppler out. Excuse me. But other than that, we have a normal wave. We have a normal waveform here. They could have changed their scale a little bit to make this waveform come all the way up to here. It just looks better rather than having a tiny little waveform. But it's not bad. So overall, that's why sometimes I'll pick pictures just so I can pick them apart. I like picking other people apart. This one, let's back off a little bit. It's a bit, not a great color image up here, but it's okay actually. It's let's see, it's a distal CCA. Let's see, 52 centimeters per second. It's in meters per second, which I really hate when machines do that. 52 centimeters per second over like 18 centimeters per second. Why did I pick this out? Pretty typical. I can't think of why I chose this particular picture. I think I just chose it just because it was there. I wanted to show something normal. I used to have little, there they are, okay. Jugular vein on top, a beautiful picture of the CCA, looks like probably mid, yep, mid CCA. Forward flow from the end diastole to peak systole is, we want to see that, by the way. I'm going to talk to you in a second about how the velocity should go skyrocket up. And then it comes down, and this person almost gets a tiny bit of reversal is okay. If it went below the baseline just a little bit, that's fine. That's early diastole. And then we have some decent flow. Let's see, what 30 is it? No, we only have a peak velocity of 110, and diastolic velocity is probably 30. So that's normal. I have some arrows over here, so let's find out why I have those. Let me back it up. Okay. We have, as you guys know by now, an ECA and an ICA. Both of them look pretty good. This ECA has low end diastolic velocity. It's feeding the face. It has higher resistance. The blood slows down more because there's more resistance at the end of the line. We tend to have continued forward flow in the ECA. There's other areas of the body, the blood flow stops entirely, and that's very high resistance. But this is fine. Just a tiniest reflection of reversal of flow, but it's not even worth looking at. That's a high resistance. And then over here, we have the proximal ICA, beautiful laminar flow. You couldn't ask for a more open window down here. And end diastolic velocity is 20 centimeters. So this is low. So this is a high resistance, low resistance. Here's the thing about arteries feeding these. We could say that we could add them or we could subtract. If we add this high resistance to this low resistance, we get medium resistance. Now, these are three different people, so the numbers aren't going to work out perfectly, but we basically have medium resistance here. This could, I could confuse this for an ECA, but it's the CCA. Or the other way we could say it is that you could take if you take the CCA waveform and subtract out of it the ECA, you will get, and I'm making this up, by the way, guys, this is not an equation you're going to run into, but it works. If I take my CCA, I subtract my ECA, I will get the ICA. And what do I mean by that? This is a mix of both. So, if I truly did remove the ECA, if I really did remove the ECA, in other words, let's say, I probably should have written this the other way. I'll write it both ways. I would have a CCA, because a CCA now was going to cross this out here. So basically, it's CCA minus nothing is CCA. In other words, CCA would equal the ICA. Think about that. What am I saying there? If the only vessel that is patent in the neck beyond the CCA is the ICA, then your CCA and your ICA are going to have identical waveforms. I could have, and actually I wish I had, said CCA minus ICA equals ECA. I hope this is making sense. This is the first time I've ever taught it like this. I just literally thought of it. Well, I thought of it right before class, but in other words, CCA minus the ICA, if we take the ICA and completely occlude it, we basically had a CCA that looks exactly like an ECA because there is no flow going to the brain. It's only going to the face. The CCA is going to look like an ECA. It's essentially now one vessel, one continuous vessel. So these are things that we can't actually see. Now, over time, the ECA, if in this situation where the ICA is completely occluded, the ECA will eventually start to develop collateral flow. That's like there's traffic up ahead. Siri or Google Maps, whatever, tells you to get off the road and take these side roads and get back on the highway again. That's a collateral flow. And so the CCA and the ECA eventually will start to feed the brain. And then things get really confusing because now the ECA looks like an ICA. Why? Because it's now feeding the brain. That's getting a little ahead of us though. So suffice it to say, the waveforms can change with disease states. The waveform of a CCA is a combination of the two vessels that it feeds. Oh, and then down here, this beautiful little vertebral artery. And you can see we're capturing views of it. Little pieces of the vertebral artery are being captured. This person has no angle correct at all. Shame upon them. And you can see that it's very hard to create an open window in this vessel, and that's okay. We don't, it's a much smaller vessel, and therefore it's not quite turbulence, it's just a little bit disturbed because it's a smaller vessel, and it's just very difficult. Not to mention, if you look at it, their gait is from wall to wall. So they're getting all velocities, wall velocity, center velocity, wall velocity. And therefore, we cannot really fill this in. So it looks disturbed, it's not, it's okay. Now, a little thing about vertebrals, they don't get plaque like everyone else. They tend not to get plaque at all. So in the vertebral, we don't tend to find stuff like that. Of course, it would be hard to find because we're only seeing little bits and pieces of it. But in general, that does not happen in the vertebral. What does happen is that the walls thicken. What also happens is sometimes people are just born with different size vertebrals, the right bigger than the left. That happens as well. And so you might notice that sometimes. But in general, rather than a single point of plaque, if the vertebral is diseased, it tends to be longer. So once again, Bernoulli is out and Poisson is in. it actually kind of acts like a long stenosis. It's usually not a stenosis per se, but it is narrow and it's longer. So then Poiseuille's. A lot of times, some doctors will ask for volume flow. And we'll learn about that in lab, how to do a volume flow. Because with the vertebrals, it doesn't tend to be a Bernoulli issue, it's a Poiseuille's issue. In other words, reduced volume flow in the vertebral arteries. Right, and I think that brings us up to, no it doesn't, okay, that's okay. I want to stay in the order that I have here. I think I just have some examples here. So nothing terribly new. Let's see. 480, basically 480 centimeters per second. (480 centimeters per second). That's significant. If we go back to our chart, well, from the chart, well, we would say 480. Well, dang it, now I gotta look at it. Well, what else can we see? We see lots of plaque. Okay, let's just quickly look at greater than 70, but less than near occlusion, right? 480 is definitely in greater than that. Yeah, from what just visibly it looked like more than 50. The ICA-CCA ratio is going to be more than 40. More than 4. I don't know what it is because we didn't work it out. And greater than 100 in end diastole. Ooh, let's find out. 151. End diastole is 151. So think about that, guys. 151. Normal flow, normal peak peak systole is more like down here, normally. So the entire waveform should be down there. That is how, well, that's actually really cool. That's a cool visual to see how large this is. Even end diastole is too fast for peak systolic velocities. And you can see some heterogeneous plaque, and some echogenics, some hypoechoic regions, anechoic regions, really. Lack of flow right here might be shadowing. Definitely a mess. Definitely this person needs surgery, actually, which we'll cover next time. What do we have here? Oh, something new. I don't think, I might have mentioned it. This waveform does not look very good, right? This is the proximal ICA. Whoop. Well, as long as I'm still, let's just come across and look at something here. Okay, maybe that's why that was there in the first place. It's normal flow. Fast upstroke, meaning it doesn't take a lot of time. There's actually a measurement we can take. Let's zoom in a little close. There's a measurement that we can take that goes from that point to that point. That time, and this is usually in milliseconds, thousands of a second, is called the AT, or acceleration time. The time it took to go from end diastole to peak systole. Let's go back over here. Now, it's a numerical way of seeing something that we can visualize instantly there's something wrong with this. But if you want to give the doctor numbers, and they do like their numbers, we can say end diastole to peak systole. The acceleration time, and I'm sorry, I don't remember what my numbers are, is increased. In other words, the time it takes to go from end diastole to peak systole has increased. In other words, what it should have done is end diastole, peak systole, there, and so peak systole should have been there, but instead it was farther apart. So, other things we could just say, just qualitatively, is simply that this is undulating. This is practically venous flow. This type of flow is called TARDIS parvis. I think I've mentioned it, but I don't think we've really gotten into what this is. TARDIS meaning tardy. You're late for class. You're tardy. And gosh, I can't remember what parvis stands for, but basically this TARDIS parvis is a I think it's like more blunted. So late and blunted waveform. We see this after a stenosis. So post-stenotic TARDIS parvis is a really clear indication that something's going on. So look at this picture up here. Actually, come to think about it, I never really didn't look at this that carefully before. Look at this. This appears, and this is why before I said this looks like laminar flow, but I'm not so sure. This looks like laminar flow, and it might be laminar. It might be laminar. I mean, just because it's TARDIS parvis doesn't mean it's not laminar. It could be laminar, just really blunted, really late. But something back here, something upstream of this, and for carotid, upstream is obviously going to be further down the neck, but something upstream happened. There had to be a stenosis somewhere. So this is a good indication. Let's say you missed that stenosis, and this happens. There's a certain exam we do, a very difficult exam with the kidneys, and that's one of the things we really look for, because finding the actual stenosis inside of a body on a vessel that's about no bigger than a pencil is difficult. But finding the results of that stenosis, that's actually easy. And then the same thing here, maybe you actually missed a stenosis because of echogenic plaque. But if you see this after that plaque, something significant happened. So there's a significant stenosis, even if you can't see it. All right. DOTP, diseases other than plaque. What time is it? 10:50. All right, yeah, we're just going to keep going. We have to. We only have vascular once a week, so we really have to keep on this. All right. This one's one of my favorites. Look at this. Look at what's going on here. We've got a line going across. Now that one's pretty obvious. And this one's pretty obvious too. In fact, it's so obvious that if I were looking at this one in grayscale, I would say, common carotid artery, jugular. I mean, if you cover up the red on that, and you only look at that, yeah, the jugular vein always lays on top of the CCA. Easy way to miss a very significant, deadly complication. But notice in color, they're both traveling in the same direction. We don't see the scale. Oh, we do see the scale. Yep, the scales. So they're both traveling in this direction. The jugular, you might have we had a branch the other day of the jugular going uphill, right? That doesn't happen. The jugular always travels downhill. There's really nothing that could, for all intents and purposes, it's always downhill. So what's going on? We have, assuming this is the same patient, we have a line coming across here. We have a line here, and it's unusually thick right there, which I have a hard time explaining why it's so thick there. This is a complication. I don't want to call it a disease. It's not a disease. It's a complication called dissection. And usually it's one layer. On this person, I almost want to say it's 2 layers, but that's kind of hard to explain. Dissection, the tunica intima has come loose. So let's see, on this one, it kind of looks like the tunica intima is continuous down here. And see how on this picture, I don't know how well you guys can see that, a little harder to see the inside layer of the vessel. So I think this belongs up here. So it's been torn down. Now there's a couple of different ways that things can happen here. It could tear down and be open at either end. This one appears to be open at either end. Blood's going through both lumens unobstructed. I have seen where, and this would really be confusing in this picture, blood traveling back and forth. Well, let's just say let's say in one direction here, but in 2 directions up there. And that would be like more of a blunt end to this dissection. So the blood's kind of going through and punching and coming back. So that's another possibility. This can be very hard to diagnose. These 2 images are pretty, you see very clearly there's something there. That's obvious. There's something absolutely there. That's not an artifact. Sometimes these guys look like artifact though. One of the problems with reverb artifact is that it shows like this is the wall here, right? Reverberation, what happens is sound bounces back and forth and you end up seeing the wall there and you see the wall a second time. You kind of get used to seeing that. And so when the one time that it's not the wall, it's not reverberation, but it's actually part of the wall, it's a dissection, you could actually miss it. So you gotta be cautious. Dissections, idiopathic dissections that just start. First of all, you may have a connective tissue disorder like Marfan's syndrome or Ehlers-Danlos. Those tend to be really tall, lanky people with super stretchy skin. They pull their skin out. They're hyper flexible. Their connective tissue is stretchy and weak. They can get dissections. They can also get other issues with their arteries, like a big old aneurysm in the belly it's quite deadly. And the other way is trauma. I saw an article a couple of years ago. A young woman's at the beach. She gets hit by a wave. Her head snaps back. She tears her intima layer, and she gets a dissection. I think she was fine because she was in a lot of pain. They figured it out. Chiropractors. Now, I used to swear off chiropractors. I did go to one for a while, and then I realized that I wasn't getting anything out of it. But God, it was awesome to have my neck cracked. But when they snap your neck, if you are typically a thin woman and you have your neck snapped by a chiropractor, you are taking a risk. Another couple of problems here. Both of these are caused by a doctor. I actually saw this happen once. It was when I was a student. What is the term? When a healthcare provider causes the problem, I believe I spelled that right. A iatrogenic injury caused by the healthcare provider themselves. And I guess in the chiropractor snapped my neck, probably caused some kind of injury. But I saw this happen to a carotid. It was impressive. So what happened was I was a student working with this doctor, and she needed to take a sample of the thyroid. And most doctors I've worked with ever since being a student use a needle, and it's called fine needle aspiration. You just stick the needle in and you kind of poke around and you get enough tissue inside of the needle. That's that. But she wanted to use a gun. I can't think of the term. Well, it's basically a little gun that shoots out a much larger needle than a hypodermic needle, a much larger bore needle, and it fires it out and it goes and it comes right back in. And so I'm kind of looking at it as a student, you're a little less aware. And she's got the needle here and the thyroid and the carotid, and she goes right through the thyroid into the carotid and back, and suddenly you see blood going inside under her muscle layer and in her neck. And the doctor immediately saw what she had done, and we pushed down, and then I think I held onto her neck for about a half an hour. And we totally played it down. That's what you do. You just say, oh, you're going to have a little bit of bruising. Yeah, I'm sure she did, considering she had blood swirling. And so what happens here is the blood is now swirling out, going around, and there'll be if you put a spectral right here, and then in the neck of this pseudoaneurysm, you'll have to and fro. And page 78 shows you a picture of to and fro. So this is a pseudo I never know where to put the rhythm. Yes. Oh, I spelled it right. Pseudoaneurysm. There's two forms of pseudoaneurysm. We'll get into that a little bit later, but this is one form where you break through all layers of the vessel. The blood comes out, but it doesn't just disperse. It gets stuck between different fascia layers here. It doesn't go any farther, but it does tend to swirl around. It's actually one of the few things that sonographers can be asked to cure. We actually can be asked to cure or fix this problem. And what we do is we find exactly where it is with our ultrasound machine, and we push and we hold down for 20, 30 minutes. And so that's what I did for this lady. So that was pretty cool. I was a student. I was already fixing the doctor's mess. She was a very good doctor. Just made a mistake. The other possibility, and this is beautiful. This is also iatrogenic. A doctor stuck a needle, probably purposely, into the jugular vein here. I'm sorry, this only couldn't find a good carotid version of this, and the only one I could find is black and white. So the jugular here, and CCA down here, and there's a bridge. So let's see, that's it looks like the ECA. It doesn't matter, ECA, ICA, what does it matter? All that matters is someone took a needle into the jugular and into the artery. That needle has now created a bridge of fluid. And of course, blood's not going to go from the vein into the artery. The artery is the high pressure system. So blood is doing, how did I get into that? Blood is going into here, and look at all the aliasing. If we could see this in color, this would be aliasing, because the blood's going like right in there. And now in the vein, you're going to have artery and venous waveforms in the same vessel. So that's an indication sometimes that there's an and this is called a AV fistula. In other words, arterial venous fistula. So that is another thing. We see these often. We actually see these in the groin between the femoral artery and the femoral vein. I found one of these when I had my own business, and it was really frustrating because the radiologists I was dealing with, and there's several of them, none of them seemed to really enjoy ultrasound, enjoy reading ultrasounds, and so they just wouldn't do a good job. And so I saw this on a person, and look at this vessel. Do we see plaque? Well, no, we don't, but what is all of this? What is going on with all of that? And then if you look at the outer, well, let's do this one here. This might be a little bit better. When we look at the outer wall, it's kind of like that. And so one could confuse this for plaque, certainly calling that plaque. But this is something else going on. This is more likely to be found in women. It's found on the internal carotid arteries and the renal arteries, the kidney arteries. When I found this, it was kind of, I was looking, and suddenly it dawned on me what I was looking at. And I was like, of course. And then I specifically said no plaque, and then I gave my diagnosis, which, you know, you can carefully, you have to, like, if you're going to diagnose as a tech, you put like, you know, like a question mark, you know, say, I think this might be this, and that way you're held less accountable. You're really not held accountable at all, actually, if you're simply suggesting a possible diagnosis. But you got to be careful. There's a fine line between suggesting and diagnosing, and you don't want to get in the business of diagnosing. Get yourself in a lot of trouble with that. Anyway, so FMD, muscular dysplasia. You know, how could I spell fibromuscular dysplasia and then not be able to spell separate? It just doesn't make any sense. All right, fibromuscular dysplasia, more likely to be found in females. This can cause increases in velocities, stenosis and such. And what's really happening is the fibromuscular layer, in other words, the tunica media is hyper growing. It's growing too much here, and it's causing a beaded appearance of the vessels. It's a hypertrophy. Ooh, hypertrophy. That's a good word. Hypertrophy. In other words, when you work out, your muscles hypertrophy. Well, in this case, we have hypertrophy of the muscles for some reason of that particular artery. So this tends to be in the ICA and renals. Gotta love those kitty cats. Once again, fibromuscular dysplasia. So if you see kind of a, real bumpy appearance without plaque, that leads, and it tends to be a female, that leads to fibromuscular dysplasia. And you can see it does cause, let's see, what are the velocities? Looks like the velocities are, I think that's a 2 right there. I'm not sure. So velocities are increased. Definitely, this is indicative of turbulent flow. The fuzziness on the top here, that also shows turbulent flow. Oh God. I don't know, I'm sorry guys. I just don't know what the problem is. Everyone's very confused about today. Did I say something? Let me just finish up. Anyway, I was going to finish up this row, and the row is finished. Let's see, what else did we have? Temporal tap. Yeah, this could wait. 11, 12, no, it's not. I'm not going to deal with whatever it is they're dealing with. I have no idea. We can skip that for now. So I have these arrows here on this model of the system. This model's hard. I wasn't going to use this model because it's hard, but all the models are kind of hard to look at. So so we have our let's just do the left side, patient's left, of course. CCA coming up here. So that is all CCA. By the way, it's very hard to go all the way down to that far down with ultrasound. That's all CCA. And then external, you see here, it has these little branches off of it. I will mention that the first branch is almost always the superior thyroid artery. It's actually good to know that. So we used to teach all the branches, and considering we really can't see them all, doesn't seem like it makes a lot of sense. So the ECA's got the branches, it's feeding the face. ICA does not have branch. Your book mentions that sometimes it does. Yeah, like 1 in a million. So every once in a while, this guy, that superior thyroid artery can come off of this side. Hence, it's either a bulb or, that's very, very rare. Generally, no branches. That goes up to this whole thing here is the circle of Willis. We'll worry about that later. Here's our vertebral. So this is the back of the neck. The back of the neck, and these are, of course, going through those vertebral arches. That too connects through to the circle of Willis. But that's not why I have this up. I just wanted to just kind of give you an idea. These arrows down here were just to remind me to say something. Because I've mentioned in class that the subclavian artery is very difficult to image. It's difficult to image because one, you got the clavicle there, but we can get it. That's actually not the hard part. The hard part is once you do a spectral here versus a spectral there versus, and let me just jump to the other side because it gets a little messy over here, a spectral here, they're all going to show different waveforms. Remember what I said about the carotid? A carotid waveform is a combination of the two vessels that come off of it. It's a combination of a high and a low resistance bed. The brachiocephalic artery, this is the whole brachiocephalic, or also called the innominate, two different names. That's a combination of, probably not the best choice in color. This one's a combination of 1, 2, 3 resistances, beds. 2 of them are high resistance beds, 1 of them is a low resistance bed. Subclavian artery is high because it goes out to the arm. The external carotid is high because it feeds the face. And then the internal is low because it feeds the brain. So I'm just going to put the number 3 here for three waveforms in one waveform. And not to mention it's really close to the heart, which causes other spastic issues, basically. Whereas if we look at here, the CCA, I'm going to put a 2 here because it's 1, 2. And if we come all the way out to the subclavian, I'm just going to put 1. It's high resistance. So the waveform changes between here and let's say right here. The waveform along the clavicle and subclavian and innominate arteries, it changes considerably. We'll see that and maybe not. I'll find someone who's a good example of that because it's a bit of a mess. Really quickly, we're going to talk about, I could also show this in class. This is called the temporal tap. That's pretty cool. So sometime, and I don't use this unless I have to, because it's technically difficult sometimes, technically easy other times, but it also can fool you. So you got to be careful. You could see here if something's going on, where it's not going on here, but something's definitely going on there. What is that? Well, if you're not sure which is the ICA and which is the ECA, well, you get on what you think might be the ECA, and you take the patient, you tell them, you don't just start whacking them on the side of the head, but you tell them, you find their temporal artery, which is right about here, and you just kind of start pushing on it at a rapid rate. That pressure wave goes backwards down from around the ear backwards all the way down, and we could actually see that wave. That's a good indication of which vessel is which. Now, it's possible to push not hard enough and you don't see the wave, so you think, oh, that must not be it. Or you push too hard and the wave, that back pressure wave, can actually go all the way around the corner and affect the ICA as well. That's why I'm not a huge fan of it, but it's definitely helpful sometimes, because I'm telling you guys, sometimes you don't know what you're looking at. The other thing, and this kind of has to do with plaque. This is the CIMT, carotid intimal medial thickness. In other words, the thickness of the two inner layers of the wall. This is normal. Let me zoom in a little bit on this one and show you what we're looking at. If I were to measure this, and by the way, machines these days actually measure this automatically. You just kind of, you give the machine an area and it'll do it for you. But if I were to measure this manually, it would be from here to here. Not the outside, but basically this hypoechoic line. Damn it, a different pen here. The hypoechoic line and the echogenic line. So that's the measurement right there, in fact. And we do not include the echogenic outer wall. That's a normal one. Let's look at one that's a little bit abnormal. And by the way, finding a chart in every book I have and every Google site I've gone to, finding exact measurements are very difficult. So I personally eyeball it. And I eyeball this, I say, yes, that's a little thick. What this is, it's a precursor. So here, I'm going to measure from here to here on this person, that thickness. And obviously, once we're in the bulb, it's definitely getting thicker there. But this is distal CCA. This is a precursor to plaque. A precursor, it kind of tells you plaque is coming. So I'm going to call this mild. It's also, by the way, I just read an article, very high correlation if you have increased IMT or CIMT, carotid IMT. There's a very high correlation to coronary artery disease. So it's also, you know, when you see that, you could also suggest to the doctor maybe they need their coronary arteries looked at as well. And this is, I don't want to call it severe, but I'll just say increased. Positive increase. So on this person, definitely quite thick. Oh, and look at that, they measured here. Carotid IMT. Mine's a little thick, but it's because I'm older than I look. I'm old, and as we grow older, the IMT thickness will increase. And so mine, when I look at mine, I always kind of go, ooh, but then I remember, like, you know what? Normal for my age. Very unusual. Very unusual. This guy. And I think it's moving around in there. I'm not, you know, obviously I wasn't there. Oh yeah, it is moving. Oh, that's right, it is moving. This is thrombus. In other words, DVT. You don't, it's not DVT, idiot, but it's basically the same thing. It's, because it's not deep vein thrombosis, deep artery thrombosis. It's DAT. I just have a V upside down. No, very unusual. You don't generally see thrombus in arteries. It can happen, but that's not a normal thing. We don't see that very often. We see plaque in arteries. And so you guys were wondering about what good uses we have for M mode. And in M mode here, and something's, I think this is a primitive M mode. It seems like it keeps starting over or something. I don't know what's going on. But there's movement. It's not a good picture at all, really, to show this, but it seems like this thrombus is moving and then like it's there, it's gone, it's there, it's gone, it's there, it's gone. And when that happens, it means it's moving in and out of that region of interest. The region of interest in a M mode is that line that you put in. That whole line is the region of interest. And so when things move in and out of that line, it's like living in flat world, and things are, that's probably a weird reference if you're not familiar with flat world, but things are moving in and out of your plane of existence, basically. And so it's there, it's gone. It's there, it's, oops. It's there, it's gone, it's there, it's gone. Anyway, let's back it up a little bit. So yeah, very unusual to have thrombus in the bulb. Notice this person's bulb is, I guess we could say that bulb starts here, but it kind of, that's kind of the bulb. The bulb involves the beginning of the internal. I think that just, okay, now I am done with that son of a, every picture, except for these guys, and these guys are just, oh, well, let's just zoom in on the colored in one. Just a quick second and we'll be done. And I can go yell at my other class, figure out what the heck their big issue is. So look at this, this vertebral artery. See what this is what we're seeing, right? We see that, we see there, we see there, we see there. And we don't see through the arches themselves because they're bone. The first vessel that comes off is the superior thyroid. Look at that. Superior thyroid. The inferior thyroid is coming off of here, down here. Let's see what else I want to talk about. Carotid. Oh, we'll get into this. We'll get into this more when we get into the circle of Willis. Oh, that's not the carotid siphon. This is the carotid siphon right here. Yeah, we'll talk about that when we get into the Willis. I don't know. There's not much else to say. It's good to study these pictures and kind of get an idea of what goes on. Eventually, we're going to talk about how these vessels are going into the face, and then actually, it's kind of cool. This one actually goes in behind the eye and eventually actually touches right here. So potential collateral pathway. But that's for another day. We are done. I had a question on yesterday's lecture. So yesterday's lecture is the asynchronous assignment. Hopefully half of you at least looked at it and typed in done yesterday, and then the rest of you do that tomorrow, right? Yeah. The rest of you just, I don't care when you actually view it, but try to remember to just open up that. I'll try to remember to put a reminder out to do that on Wednesday. I had a question on a day off. What was it? Columbus? I don't think we have that day off, but
We don't.
We don't. You already checked. Okay. Yeah. the same question again from my other class. I'm going to throw them. Oh, and I had a really good question last night that I will address tomorrow. So why would I bother telling you? Well, just so you know, I'm going to address that tomorrow. It's about the something in physics, though. So, all right, I think we're done. This lecture, if you're going to look at it again, it won't be up for a few hours because I got to run.
Hey, Kurt,
Yep.
what was that physics question so we can ponder it until you tell us tomorrow?
Oh, man.
Also recording.
Yeah, you know what? I will stop the recording.